Hello, everyone. This is John Robinson from Child and Family Focuses Prevention Education Program. Welcome to PEPCast. We have a great interview here for you. I'm going to be talking with Sarah Laurel from Savage Sisters. Savage Sisters is an award-winning organization that focuses on harm reduction. Does a lot of work in Philadelphia and Kensington, and they've been making some waves in Delaware County as well. Uh, some of this interview happened over a year ago, so some of the information might be outdated. So I encourage you to check out the website. I'm going to put a link to that in the description below. I also decided in this interview so we talked a lot about some factoids and things like that, to put some captions in some portions of the video, so people would basically get an idea of some of the things that we were talking about. I'm going to put some citations at the end of the video as well, and at the end of the podcast. Please enjoy the interview. As always, I'd like to give a shout out and some credit to the rest of the people in my department, and also to the Department of Human Services in Delaware County, specifically the Division of Drug and Alcohol Services. And without further ado, let's jump into my conversation with Sarah. This computer. All right, we are recording. I am here with Sarah Laurel of Savage Sisters. She has done award-winning work in the community of Kensington and Philly for a lot of different issues surrounding substance use, prevention, harm reduction, all of those kinds of things. And I'm here to talk with her more about that. Sarah, how are you feeling this morning? First, I want to say I really like the caption on your shirt.
Oh, thank you.
Yeah,
My
could you tell us
friend
a little?
made this for me.
Oh, a friend made it for you. Okay. Could you tell us a little bit more about what that means to you? It seems pretty straightforward, but yeah, if it means like something more significant to you, I'd love to hear that.
Yeah, absolutely. I think, being a resident and a harm reductionist in specifically Kensington and doing this work on a regular basis, we try to emphasize the fact that the drug war has been systematically oppressing people in a myriad
Yeah,
of different ways. And it essentially is a war on us. The higher ups don't have those consequences. The
sure.
consequences are felt heavily in low income communities, minority groups,
Right.
marginalized groups, and specifically people who use drugs.
Yeah, absolutely. The war on drugs, as we both know, started. You could have said it started in the 70s or the 80s, depending on what starting point you want to use. But it has come out now over the past decade or so, and maybe even before. I mean, there were suspicions about this beforehand, but especially over the past decade, that it really was a way to keep certain groups of people in line. It was not meant to be a helpful policy, and it's been a failure, kind of pretty much an objective failure at this point.
Absolutely. There was a large push for like a moral standard that was being
Hmm.
presented by, let's just say, white America and people in
Yeah,
charge.
I'm fine with that.
And those individuals specifically were not abstinent individuals. In fact, they drank heavily
A lot of times,
often,
yeah.
and they chose specific substances to demonize. And along with
Hmm.
those specific substances, there came a minority group that was there. So we had the
Sure.
opium dems with Asian individuals, and they kind of demonized fat. And then we saw the crack epidemic with
Yep.
Black Americans.
Right.
And then we also saw Latinos with the marijuana. So
Hmm.
there was this very there was a correlation to what the substance was and which minority was going to be demonized alongside that substance. And it is effectively
Hmm.
causing more issues within our judicial system and our public health system.
Yeah, and along those lines, it's interesting you mentioned how it targeted certain groups of people, like the Black community, the Latin community. The when the opioid epidemic happened, and it not entirely, but mainly affected white Americans, then all of a sudden everybody was like, we need to come to the rescue. This isn't a moral problem. This is an illness, something that advocates like you have been saying for the longest time, but people weren't willing to listen until it happened to people who kind of looked like you and me.
Right. It was a response due to the wrong people dying.
Right, absolutely. That's a harsh way to put it, but a great and accurate way to put it. Out of curiosity, have you read the book The New Jim Crow?
No.
Yeah, it's by I think she's a sociologist named Dr. Michelle Alexander, and it came out around 2010. And there's been an updated version of it since, but it essentially, and I recommend this to anyone who's listening or watching. This book goes into the very racially charged aspects of the drug war and the origins that it had itself in, and how it can kind of tie in sometimes with certain criminal justice policies, and why people are advocating for reforms and even making reforms now in some cases. But yeah, it's an excellent book for anyone out there to read. So could you describe to me, Sarah, how you got involved in the work you do, both either from a personal or professional standpoint? You can go into as much or as little detail as you would like.
It was an accident.
Okay.
So very brief history on me. I'm born and raised in South Philly.
Hmm.
Um, my mom's Irish Catholic, my dad's Middle Eastern, so I kind
Okay.
of come from a mixed cultural
I, I,
background.
sh- I shouldn't have made the assumption I made when I said the cultural thing, so I apologize for that.
Oh, I don't even know what you said, but
I basically assumed that you and I were both just white, but I shouldn't have made that assumption.
technically I'm BIPOC.
Okay.
But um that's neither here nor there. I went through school, did my thing. I spent a couple of years in Delaware County, then came back to Philly,
Hmm.
worked for a hotel chain as a business professional wearing a suit, got prescribed Percocets for carpal tunnel.
Mm.
Um, and that led to like a decade's worth spiral that landed me unhoused and
Hmm.
using multiple substances. I was a polysubstance user. Just to give you an idea, that's just a fancy way of saying I did a lot of stuff. So
Right.
I was
More than
a
one.
IV drug user, cocaine,
Hmm.
heroin, crack, Xanax,
Okay.
and I
So
experienced a
injections
trauma.
mostly.
Yeah, towards the end of
Okay.
it, I was
Right.
injecting. um, I've been to treatment 28 times. I've been to jail several times. I've been brokered in and out of treatment facilities and recovery houses several times. And when I was unhoused in Kensington, at one point, I had a trauma. I went out second story window, had to stay
Oh,
in the
wow.
hospital, get medical in my legs, learn how to walk again. And a friend of mine had an empty house in South Philly and said, "Do you want to come here and start a recovery house?" And because of all of the negative experiences I had through the system, I agreed to it. I had
Hmm.
zero desire to stay sober. I had zero desire to help people. I was in a wheelchair. And when I
Okay.
got to the house, the only thing I had was my wheelchair and a clear plastic bag with a dress that I was cut out of, and it said
Hmm.
Savage. So she said, "Well, we got to name the house." I said, "Savage Sisters." It began very organically. It was just me and two women that I was actually incarcerated with that happened
Hmm.
to be sober at the same time or
Right.
attempting to be. And as I went through the system, I realized that I was in this like bracket of like super low income or
Hmm.
no income. And I didn't have access to certain resources
Right.
that could help me on my recovery journey. I had to do something physical. I started doing kickboxing, yoga,
Okay.
Reiki, just for myself. And then I brought
Yeah,
my friends
yeah.
with me. And that's how we built the housing program very organically. Um, my two friends passed away since then. And then my
Oh, I'm
partner
sorry.
died in my arms of a fentanyl overdose.
Oh, my
And
goodness.
I decided to go back to Kensington as a person in long-term recovery and start
Hmm.
doing outreach. I started doing it from my stoop. I didn't know what harm reduction was. I
Hmm.
had no idea what I was doing. I was just going there to help my friends. Um, and there were some giants in harm reduction in the Philadelphia community that kind of took me under their wing and said, "Hey, this is what harm reduction is.
Hmm.
Like what you're doing is harm reduction." And they said, "If you want to help, do this, do that." I brought my siblings. I have 9 siblings. I asked them to help me, and then it grew.
Okay.
We have 11 sober living homes. All of them have access to free private practitioner therapy, kickboxing, yoga, and Reiki in-house. We have a drop-in center in Kensington offering showers and wound care. We have
Wow.
a mobile syringe program. We have a mobile unit that hits the Delaware County community now, and we do nationwide trainings on harm reduction, drug trends, including xylazine, and updated overdose reversals.
Sure. So
That's my
could you?
story.
Yeah, yeah. And thank you so much for sharing. And this is obviously something that's deeply, deeply affected you personally, and it turned into just sounds like a lifelong mission, essentially.
Yes, but accidentally.
Okay. I think a lot of things happen that way accidentally. I think we fall into things. I think life rarely goes completely according to plan.
Right, that's fair.
Yeah, and you just got to take some opportunities where you see them, and it sounds like you saw this avenue, and you were like, this is something that I don't want to say maybe, I'm the perfect fit for necessarily, but it's something that is meaningful to me. Would that be an accurate assessment?
Yeah, everything we do has deep meaning, and
Mhm.
everybody on my team is recovering from substance use and
Right.
homelessness.
Okay. So the one thing that a couple things you mentioned in there, and I do want to get to the idea of harm reduction in a bit, as well as prevention, some of the, similarities and difference between those approaches, as well as, recovery, because I think sometimes those terms are used interchangeably. But before we get into that, I'd like to basically kind of talk about, you mentioned like how many different activities you have at the Savage Sisters house, and could you talk a little bit more about the importance of staying active and keeping busy in recovery?
Sure. I don't, so staying active for anybody is
Hmm.
important. And having connection and community
Right.
is highly important. There's scientific studies that date back decades that kind of show the correlation between mental health and community connection.
Sure.
Um, I would say specifically for my programs and what I'm doing for the friends that I serve is changing that systematic approach to it, where you're given one way to quote unquote
Yep.
recover. So the programs offer my friends an autonomy to decide how they want to heal. Not
Sure.
everybody likes talk therapy, maybe
Right.
art therapy, maybe music therapy. We
Hmm.
offer all of that. Not everybody, wants to get active by doing kickboxing, but for a
Right.
large majority of our women that have been possibly sexually assaulted, exploited, whatever, it's an
Yeah.
empowering moment for them. We offer yoga. We have more male residents that attend yoga than female residents. The
Oh,
females love the
wow.
kickboxing, the men love the yoga. So
That's
we found
interesting.
that, isn't it? We found
Yeah.
that offering these opportunities for our friends, there's an ownership of their life at that point where it's like, I get to pick how
Hmm.
I want to heal. And I get to say, this works for me. And when we empower an individual and give them governance over their own journey,
Hmm.
we allow them to be a part of it. It's
Yeah.
not a dictatorship. This is us
Right.
working together. And we have the highest rate of long-term recovery in the state right now
Oh, wow. That's
through our
amazing.
program. So, and I don't attribute that like, oh, it's not like Savage is amazing. It's that the people that I'm serving
Hmm.
are amazing. And when they're
Yeah.
invited into their journey, they can shine in whatever way works for them.
Absolutely. They're very motivated, and a lot of the people who I've known who have been in recovery, they basically, like, the ones who really are motivated, they are some of the most motivated people you will ever meet in your life, the most driven people you'll ever meet in your life. And a lot of times, like you mentioned, they don't have that autonomy, or at least they're assumed that they can't be trusted with that autonomy. And that varies from person to person, but that assumption shouldn't be made. And the idea that, people, when they are given the agency, kind of like you said, and they can do these things, because I think a lot of times when people get into addiction, in a lot of cases it's because of the fact that they're trying to escape something that's been very, like, a lack of freedom they've had. So it's the empowerment sounds like it's a very, very important part of what you do.
100%.
Okay.
It
So
is. I can't take credit for how my residents recover. That's them.
sure.
That's the hard work that they put in. But I just think that no matter what you're doing, individualizing the services and creating
Right.
a real deep connection and investing in a person
Right.
um, is just not the way our system is built to help
Hmm.
people, whether they're coming from rehabilitation systems or prison systems or whatever that looks like for
Right.
them. Um, it's been successful so far, and we can connect with them in a way that others can't.
Right, because the systems around us want to work in the ways they want to work. Like, they don't want to adjust for other people always. Yeah. So could you get into a little bit more about, prevention, harm reduction, recovery? Because sometimes those terms are used somewhat interchangeably and thrown around, but I don't think we often think about what they mean and the distinctions between those things.
Sure. I think for me personally, the way that our mission attempts to talk about prevention, as far as the education piece, let's say with high school students, college students, and things like that, um, is to give actual real life information and data. We don't want to use fear mongering. We don't
Hmm.
want to go in with that,
Yep.
drug war propaganda and be like, drugs are bad, okay? Like we
Right,
are aware
Mr.
that
Mackey.
there's consequences for drugs, we're aware, but never in my life did anybody ever come to me as a teenager and say, drugs feel great.
Hmm.
But this is what the consequence of overuse or chaotic use or mixing substances can do. I have a vivid memory of taking a Xanax for the first time and thinking,
Hmm.
because they were so small, I needed to take like 5 of them.
Oh
So I
yeah.
did. So I took 5 because I was like, these are so tiny. I had no
Hmm.
idea what they did. It's a complete blackout drug for a kid that size. And what we try to do with prevention is say, this is what it looks like. This is what it does to your body. These are the negative consequences. A large majority of prevention, we want to get into the hands of individuals who are not chemically dependent on substances. They're
Right.
using socially, recreationally, experimentally.
Yeah.
And so we want to give them the most up-to-date, accurate information. We remove the judgment from it
Sure.
and we open up the floor and say, what questions do you have for us? We don't go in there and say, look, I was in jail. Like,
Hmm.
boom, if you
Scared
drink, you're
straight.
going to die. Because that makes no sense.
Right.
Because all of our parents drank. So it was
Yeah.
like, how are you going to tell me drinking is bad, but my mom drinks a glass of wine
Right.
every night? So it can't be that bad. So I think just like bringing an honest harm reduction lens to those trainings is super important and it helps, with prevention. I also think a heavy focus on mental health, okay? Like
Yes.
eating disorders, undiagnosed eating disorders,
Hmm.
sports related injuries for teenagers
Yeah.
up to college age. These are the spaces where we need to talk to people and be like, when you get this medication, you're going to feel like Superman. Like you're
Right.
for sure going to love it. So like, how do we proactively discuss that
Hmm.
and make a plan in place together? Um, and diagnose mental health and make it okay to like get those treatments, because a lot of beginning stages of using substances is untreated mental health and they're self-diagnosing.
That's so important. So the other thing you mentioned in that is this idea of, like you said, being honest with the kids. And a lot of the kids, I think that's because with some of the kids that we work with in the prevention education program at Child and Family Focus, um, what we encounter is like you mentioned, the scare tactics, because like it's going to be bad for you. Kids think they're invincible up to a certain age, and
Mhm.
like what I've found gets them is when we sometimes do vaping speaking engagements, and when we talk about it, the thing that kind of perks the kids' ears up is not these are the harmful side effects. It's you're a shill, like you're you're shilling for these companies. They're trying to get one over on you because they don't want to be that. They a lot of times they don't necessarily think too far ahead, but they're very afraid of the idea of, well, I don't want to be like tricked.
That's valid. I think there's a lot that needs to change within that conversation when it comes to kids. So
Hmm.
talking about smoking, talking about vaping, talking about marijuana,
Hmm.
the scare tactics there. There are several locations in Pennsylvania that are youth-based treatment facilities that are
Hmm.
very expensive. I'm talking 10 grand a month to go and live in one of these properties, and over 92% of them are filled with underage, like under 25, I'm sorry, under
92%. Wow.
25 individuals that are their substance use issue is marijuana.
Okay. And how
That
do you
doesn't make sense to me.
yeah, well, how do you think the because it's not fully legal in Pennsylvania, but maybe some of the relaxing of regulations has contributed. Do you think that that's contributed to that at all in terms of some of the misconceptions about it? Because on one hand, back in back before it was like reefer madness, all this scary stuff, and now I think among some people, what I hear is this thing where, oh, it's harmless. It's not that there's nothing, that it's not going to harm me because it's medicine. And I feel like there's kind of a happy medium between those two.
I think those specific locations that I'm kind of talking about are a capitalistic approach to a problem that doesn't exist currently.
Gotcha.
I don't think that a 19-year-old boy who's gotten caught twice smoking marijuana has a substance use issue and needs to
Yeah.
live in a sober living facility that's 10 grand a month.
No, that's
I
very different.
think what's happening is those individuals, because of the demonization of all substances, we're now saying if you do anything,
Yep.
you have to get help.
Right.
And so I think that is hyper focused on the youth.
Hmm.
And it makes us less able to interact with our youth because they don't want to disclose.
It does, because we're, as adults, we're not always modeling that behavior that we're expecting from them. And
No. And how do we create a safe space where they can talk to us about something if they think they're going to be criminalized for it?
right, right. And because I think that one thing, and this kind of speaks to what you were saying, is the idea that there's degrees to these things. It's almost like when we talk to when people talk to kids sometimes I think there's very much this attitude of, if you use, you're an addict, like you were kind of saying. And it's not really there. I mean, there are degrees to addiction that you and I both know about, where it occurs in stages, or maybe even not addiction would be the wrong word, but just substance use, where like it's experimentation, and then like, problematic dependency, addiction, like all those things kind of going along. And I think we have this attitude a lot of times, and I think this is especially true with alcohol among adults, where it's like, well, if I'm not an alcoholic, I don't have a drinking problem. And it's like, well, there's degrees to this. There's problem drinking, there's unhealthy drinking, there's, social drinking. Like, I think that we don't often make those degrees of distinction enough. What are your thoughts on that?
I think that any time that as society we try to do something that's like very black and white and say like drug addict, sober, abstinence, like that there's only two ways to it.
Right.
Every single thing that we do as humans, there's a continuum.
Absolutely.
That's ever changing. And when we minimize that experience for you're talking about billions of people. Every person is going to experience a different level with substances.
Right.
Some use problematically, some use and they're chemically dependent. Some are chemically dependent but don't have substance use disorder.
Right.
That
Exactly.
exists. So you can be chemically dependent on psych meds, but you don't have substance use disorder.
Yeah.
Understanding that scope, that continuum of what that looks like, where there's chaotic use, what are the consequences of this use? I think we've been pigeonholed into this abstinence or absolute junkie. Like when they're like, there's no in between. There's no in between. That's not real. And it's unfair, and it leaves no space for us to individualize care and talk about things in a holistic lens and scope. Because with one thing that we've learned from the beginning of time, people are going to use drugs. Everybody's going to use drugs in some way, shape, or form, whether it's coffee, cigarettes, marijuana, cocaine, alcohol, sugar, that we're going to consume. It's just a matter of how we consume, the information that we have before we consume, and whether our supply is safe or not.
Right. And the drugs that I use are better than the drugs that you use. Like there's that attitude too. Like I'm at least I'm not doing
there's
this.
Definitely a hierarchy.
Yeah.
And that's intentional as well.
Yeah, absolutely. So one thing I do want to touch on a bit is the idea of, kind of when it comes to sort of the stages of things, because prevention it kind of deals with things before they happen, hopefully. Harm reduction is kind of meeting people where they're at, and recovery is kind of the process of, okay, this is what this is what you've been dealing with. How do we get past it? What do you think are some of the benefits and pitfalls you see in all of those areas, and when do you think each approach would be appropriate?
I mean, I think the individual would have to kind of be a part of that conversation.
Very true.
I think for the substance use model, kind of overall in general, for decades, it began when it comes to substance use disorder or quote unquote addiction. It began with the acute withdrawal stage, which we're too far gone at this point.
Right.
Prevention, in my opinion, should be education, proper mental health diagnoses, and all of that. When it comes to harm reduction, that is the space, the 1, 5, 10 years prior to an individual, either becoming chemically dependent or getting diagnosed with substance use disorder, keeping them safe in that space while they do whatever it is that they do and consume those products or substances. And then we have that recovery journey.
Sure.
There's no way to say like this is when it should take place. You can't do that for individuals. You have no way to know when they're going to get from one stage to the next.
Yeah.
But I think that one of the biggest things that we are pushing up against the system with right now is that harm reduction has to be the most important stage, because we need to keep
Okay.
people as safe as possible
Mm-hmm.
during all of those times. We have to remove the stigma, the judgment, that hierarchy of what substances are good versus bad.
Mm-hmm.
And we need to just get to, this is a public health
Absolutely.
situation. It has nothing to do with anything but public health and safety.
Right.
I don't know if that answers your question.
No, I think it does, and because I'm glad you mentioned that because every substance has, its in some it has different dangers to it, and different pitfalls and things. And in some cases, like if we look at marijuana, it has some medical benefits, but that doesn't mean it doesn't have a downside either. And it's instead of looking at it as this is the degrees of how bad it is, maybe looking at it as these are kind of like you were talking about before with education, empowerment. These are the effects. This drug might be more addictive than this drug, but this drug might be more dangerous in the moment. This drug has these effects. This drug might have these health effects, but it might have also these health effects, and kind of doing it in a much more nuanced way than just these are this is the hierarchy like you were talking about. You mentioned a term a little earlier called chaotic use. I think I would it sounds self-explanatory, but could you describe what that means a little bit?
For when I have a lot of friends that I serve
Mm-hmm.
and they aren't chemically dependent on the substance, maybe it's meth, maybe it's, cocaine. They do not experience chemical dependency clearly, and they don't use regularly. They still maintain like a regular life.
Right.
But when they do consume, it can get chaotic. They can make poor choices, spend money in a
Mm-hmm.
way that maybe they don't want to, or have some judicial consequences, legal
Right.
consequences. So when you have chaotic use, kind of like how people used to say, like, oh, binge drinking,
Yeah,
um,
that's exactly what came to mind, because a part of my experiences, I'll just say.
yeah. So, I mean, only an individual can say, like, I'm a chaotic user, meaning, like, most of the time I'm fully fine and, like, substances I can take or leave. But once I do it, I'll go on like a little bender,
Right.
So we try to reduce the risk around chaotic use, just by having a conversation with people. But that's up to them to identify in that way.
Right.
Um, it could be prescription medications. It could be that somebody, maybe their diagnosis of their mental health meds is off and they're like taking too
Mm-hmm.
many. And then at the end of the month, they
Yep.
don't have that script for a few days. So they
Right.
maybe do some chaotic things. Like I don't want to define it by one situation. But I
Sure.
do think that chaotic drug use, and that's alcohol too,
Right.
um, doesn't sound as bad. People don't like to say, like, oh, I'm a binge drinker,
Mm-hmm.
Um, people don't
Yeah.
like to be kind of pigeonholed into that.
Pigeonholed, labeled, and all that. No, but when you mentioned that, there's a couple of situations I can think of where, like, if we're talking about individualizing, there was a period where I was not necessarily in the best headspace, and I was on certain medications, and I, because I wasn't in the best headspace, I started to become overly wary of certain and tried to self-diagnose certain side effects that I was most likely incorrect about. And so I was like, well, I'll just figure this out myself. I'll just figure out
Yeah.
how to take these myself. And it did not end well at all. So and then even with, like you mentioned, drinking, there's this aspect of, I think, when people, like, some people might be fine with alcohol or have a healthy relationship with alcohol when they are going through a good time, but then when things get a little rough, they it turns into, like you said, the benders, the binge drinking, and to a point where sometimes it affects the people around them, and they might not be dependent on it, but it creates problems for them and for other people around them.
Yeah,
Okay.
basically.
Okay. So, you mentioned the idea of, like, how xylazine is becoming much more effective. Could you describe to people what that is, how it became prevalent? Um, and there is a misconception that I learned about recently that it's not necessarily an opioid, but it's connected to them or something like that.
Yes. So without getting too sciencey, because I don't
Hmm.
want to, like, confuse people, xylazine entered the drug supply, it, really about 7 years ago in
Oh,
Philadelphia's drug
wow. I
market.
didn't realize it was that long ago.
It's been a long time. And it was an adulterant, which means the majority of the supply was, let's say, fentanyl, and then
Hmm.
it was cut with some xylazine. The
Gotcha.
idea was to
Okay.
add this animal grade tranquilizer
Mm-hmm.
to
Insane.
the fentanyl supply to stretch that euphoric feeling. They were trying to give the dope in Philly legs, meaning they would stay
Mm.
higher longer.
Right.
What ended up happening, especially during COVID, um, was that supply started kind of flipping over. So instead of it being majority fentanyl with the cutting agent xylazine, it is now completely switched, where
Mm-hmm.
we have not seen a sample with more than 1 part fentanyl to 30, 40, 50, 60, 70 parts xylazine.
Oh wow.
So the
Okay.
supply is 99% xylazine now. It's been tested for several years. It is not it's not an opioid. That is an incomplete sentence to say that it
Sure.
is not an opioid. Narcan, naloxone does not work on it. So
Okay.
we've updated withdrawal protocols, and there are some very negative side effects along the lines of skin ulcerations.
Oh wow.
Um, so we're seeing just an example. I think one of our major hospitals had an uptick year over year of 39% increase in amputations. So
Wow.
it this is very like sciency. So I don't want to get like too overwhelming with it, but um, we don't have any human studies on xylazine and the effects of the human body. The
That
only
because
thing
it's
that we
new?
Well, it's not new
Relatively, I
to us.
mean.
It's
Yeah.
7 years, but
Right.
it's new to the medical research world.
Got you. Okay. That makes sense.
So there's a lot of reasons. Some people get the wounds and some people don't. However, the wounds are the people that we serve in Kensington. There's about 650 to 800 unhoused individuals. More than half of them do experience wounds. Some don't, like I said. Those wounds are varying from small, like almost picking pock wounds to
Mm-hmm.
bone and tissue and muscle exposed
Mm-hmm.
down
Wow.
to the point where the wounds become necrotic and they need to be amputated.
Mm-hmm. Yeah.
So a
Okay.
lot of negative health consequences, and we're trying as much as we can to reach our friends from a public health aspect.
Sure. So when you say a public health aspect, could you describe a little bit more about what you mean by that?
Sure. So our friends, we don't have any public restrooms or showers in
Mm-hmm.
Kensington for those 800 unhoused individuals.
Oh wow.
And obviously, not having access to a toilet or a shower is going to increase the rate of infection spreading. It becomes a public health crisis when you have this small condensed area and you
Sure.
have many individuals with open, gaping wounds and ulcers that are infected. And that they are just literally in the residential community without an opportunity to use a toilet or take a shower. So it lowers the likelihood that those wounds will heal properly. It increases the likelihood that they will need an amputation.
Mm-hmm.
And it puts them in a very vulnerable state when it comes to substances, overdose risk, and things like that. So obviously, we need human studies on xylazine. We need to update withdrawal protocols. We need to increase wound care preparedness. But we really, really, really need to get our friends toilets and showers. So
Yeah.
in a first world country, my ask is I need showers and toilets for my friends.
Yep. That's a reasonable
um,
ask.
and we've been asking for 6 years.
6 years. Wow.
Yeah.
Okay. So it's not based on what you're describing, it sounds like this isn't just a drug epidemic. It's a drug epidemic that creates other epidemics, include like the skin ulcers that you're talking about, and the infections, and it I almost said bleeds over. I'd rather not use that term in this context, but like I guess literally though, like it kind of bleeds over into other aspects and other medical issues that also affect the community in a very public way.
Well, you have to consider the residential community that it's happening amongst. You also have to consider the urgent cares and hospitals being overwhelmed with individuals that, quite frankly, don't need to be hospitalized, but they have no other avenues to go to get
Got you.
service.
Okay.
So it is exhausting our medical systems.
Mm-hmm.
It is endangering our residential community. The toxic drug supply is also exhausting our emergency services because they're
Mm-hmm.
responding to overdoses. And
Right.
really, we need to come together as a community and figure out the best way to handle this.
Mm-hmm.
It's now been detected in 48 states. I mean, Savage Sisters has been jumping up and down about this for
Mm-hmm.
6 years. I don't care how many times people get annoyed to see me talking about xylazine. I'm not going to stop talking about it.
No, it's
Um,
important.
it's now been found in all these other states, and it is steadily growing in their drug supply.
Right.
It's a lot cheaper. It is about $6 for a kilo. Okay, so of course the
Okay.
criminal market is going to turn to xylazine. You know why? Because nobody asked for xylazine, but now
Mm-hmm.
they're chemically dependent on it.
Right.
And it's a sedative, so it's giving people that feeling
Yep.
that that's putting them out. And unfortunately, every time we hyper focus on one substance, the criminal drug market responds with a more lethal, potent, easily accessed substance.
Right. Thank you all so much for watching. I hope you enjoyed that conversation. If you did enjoy it and you want to have and you want to see more conversations like these, or see part two of this conversation, which will be coming up, please like, subscribe, or follow. This video, and you can certainly learn more. I also highly encourage you to check out Savage Sisters' website. Um, for more information about them. There have been a lot of changes in the organization since I interviewed Sarah. So I definitely would go to their website for the most up-to-date information. This interview with Sarah, when I spoke to her, was in November of 2024. Or I'm sorry, November of 2023. So yeah, it's important to keep that in mind when having this when thinking about the data, and go to their website. Please check out the work they do. It's amazing work, and make sure you have the most up-to-date information. They also, do a lot of things like Narcan trainings or naloxone trainings, which can be a life-saving measure for people who are experiencing opioid overdoses. So yeah, please check out their stuff, and check out part two when it comes out. That'll be coming up. If you want to check out our previous interviews, we had one with Julie Smith of David's New Day that will be in the description below, and yeah, I'll put some information about our organization in the description below as well, so you can learn a little bit more about us if you don't know much about us. But thank you as always for listening, and we look forward to next time. And please leave a comment if you have any thoughts.